accepted. Tick.
एक करस्पॉन्डेंस पूरा हो गया ना.
Good evening, ladies and gentlemen. Welcome to another interesting episode of webinar hosted by Mumbai Hematology Group. And today have we two very interesting topic, AI in Hematology, Friends or Foe, by Dr. Pranta. Another interesting topic that we have is the changing paradigm treatment paradigm of CLL from continuous to time-limited therapies. All these wonderful programs which has been running, I guess this would be the longest running academic web series, more than 5 years plus every Saturday and Sunday, courtesy the brain of Mumbai Hematology Group faculties and our program director, Professor Dr. M.B. Agrawal. And I would, everybody knows he's a teachers of teachers, somebody who comes with great organizational skill. But today's introduction about him from my side would be more from a management graduate from IIM Bangalore and somebody who's a pass out from National Law School. My learning over last 2 decades has been he's a lesson in organizational management. He's a lesson to acquire on how to identify great talent and manage them over a period of time. He's an opportunity provider to amateur, young professionals, and also experts on one platform. He brings the best across the world. He is a great expert on time management and is an excellence in communication. And to me, he's a great combination of left brain and right brain of our brain, a great clinician, and somebody whose yield per minute would be absolutely amazing. That's my reading about you, sir. May I request you to take it forward from here?
Thank you, Dr. Manoj, for all those words. So, friends, good evening to all of you from India. As was mentioned, we have got 2 web lectures today. And as I had introduced in the last Thursday webinar, that these Saturday, Sunday academic events have now been moved to Thursday as per the demand from everybody. And we will be having these on every Thursday. So that is 2 web lectures, 6:30, 7:30 Thursdays. So try to make yourself free by 6 o'clock. Eat something and join us for this 2 hours marathon. So today we have utilized brains of 2 experts, Dr. Pranta Chakrabarti and Dr. Gaurav Dikshit. Dr. Pranta Chakrabarti will be the first orator. The subject is fascinating to today's student in any branch of not only medicine, but any branch of life. That is AI in hematology now. Friend, or brought to you by Mumbai Hematology Group, supported by Intas, Glenmark, Unipath, Natco, Lucian, managed by Perfect Square. I thank team Intas, Glenmark, Natco, Lucian, Unipath, Mr. Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Pranter and Dr. Gaurav. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your Thursday evening from India. Next Thursday, 28th of May, 6:30, we have Anshul Gupta from Lucknow speaking to us on chemo-free treatment of ALL in 2026. Following that, we have Dr. Dev Ranjani Chattopadhyay from Kolkata speaking to us on targeted therapies in AML, the changing paradigms of AML therapy. So that's next Thursday, 6:30, 7:30. Few words about Dr. Pranter. Honorary Professor, Health and Wellness, Sri Sri University. Chief Medical Director, Suga Health Corp, Chennai. Member, Dean's Council, Indian College of Artificial Intelligence. Mentor, Rotary Life Beyond Cancer District, 3291. Founder, Chu Mentor Academy. Mastermind, cyberneticcare.com. Ex-professor and head, Hematology, NRS Medical College, Kolkata. After doing MD in internal medicine, he did DNB in internal medicine, followed by DM in clinical hematology from AIMS, New Delhi. He's the recipient of many national and international accolades, including Royal College of Physicians International Bursary, Harold Gilson Fellowship, Marie Curie Action Fellowship. Besides, he has received specialized training in ethics of human subject research, biostatistics from Johns Hopkins University, Baltimore, stem cell transplantation from King College, London. He's a professional member of ASH, ISH, BT, API, IMA. He was the scientific secretary for the 51st annual conference of ISHBT held in Kolkata. His areas of special interest are hematopoietic stem cell transplantation, thalassemia, and translational research. Well, we invite him to give us some idea about this subject, about which we know very little, that is AI in hematology, friend or foe. So, dear, over to you.
Thank you, sir, for this lovely opportunity. I'll start my screen sharing. Just a moment. So, yeah, actually, I have been speaking on similar topics for almost now, I think, more than 2 years. But every time my perspective, my knowledge, and the way the world is reacting to it changes. So I thought I'll just give you an insight today, and I'll also try to tell you as a hematologist what we have to be prepared for. So this was the caricature generated by ChatGPT in February. And then obviously now I'm trying to understand whether it's a friend or foe. I'll give you basic insight into what AI is, what are the generations, why AI is a good tool in hematology, has it already influenced hematology, and then how can it create problems also. So then we will take a poll possibly whether it's a friend or foe. So basically, it is just a copy, and we are not calling it artificial intelligence now. We are trying to rename it as augmented intelligence, but we are trying to reproduce the human brain's functions. And remember, we have given the capacity. So let there be no doubt, though there are certain publications coming in that it is senescent and it is thinking, but it can do something which our parents wanted us to do, memorize and vomit out. But it can also think and create, it can speak, it can generate, it can even judge and make decisions. So this entire basket is AI. Within it came machine learning, which were algorithms, and then within it is deep learning. Now, in the last 5 years, especially post-COVID, if you see that within deep learning, we have had what we call as generative AI, and then LLMs. And during COVID, we came to know about the GPTs, especially ChatGPT, but now there's Gemini, there's Claude, there's Perplexity. So we are trying to get several tools, several methods, several algorithms to make a good copy of our brain. And so if you think that the whole thing is very recent, it is not. The work started much before most of us were born. At that time, we had AI 1.0 in the form of symbolic AI and probabilistic models, which said, if, then what, right? So decision-based trees. So as an expert, like Professor Agarwal could say that if I see this, then I deduce this. This was taught to the computer. And then the computer, in general terms, could say that whether this picture is of a cat or a dog. With this kind of very, very simple AI, IBM's Deep Blue bet Kasparov, right? And we had rule-based clinical decision support tools, which we are still using. The problem then was that human logic errors and bias were there. And if the human who was developing it was biased, the machine was more biased. Then in the second decade of this century, we had deep learning, as I showed you, which was a part of machine learning. So it can predict and classify information task specific. So now it will not only tell me whether it is a cat or a dog, but how many dogs will be in the park at noon, say in front of my house. and photo searching without manual tagging. So it's there in all our phones. Voice to text, language translation. These are all part of AI 2.0. In healthcare, we had diabetic retinopathy detection, breast cancer, lung cancer screening for images, skin condition classification, predictions based on electronic health records, and still most of it is being used today. Here, the problem was catastrophic forgetting, right? So it was not remembering early parts of a long sequence of text because while it tried to analyze that, it forgot. And this happens to us during exams also. Then, just in the pre-COVID time, we had something which was called as foundational model. That is what we are playing with today, and generating new content, be it video, text, sound, images, and it is self-supervised learning. So I'll give you a brief idea of what self-supervised, unsupervised, all these are, because now it can tell me and explain the difference between a cat and a dog, other than saying where they are. And you have MedPalm, MedPalm 2, PubMed GPT, BioGPT, and even Google Health, Anthropic Health. So all these things, Cloud Health, are there. Here, the basic problem is that it can be confidently incorrect. Mm, so someone was telling me, it is just like your spouse. So it can hallucinate like anything. Like if you tell it to write a review article, even on AI in hematology, it will generate a review article giving you 50 references. I'm sure 48 of them would not exist. So this grounding and attribution bias related to underlying training data is a huge challenge, but I'll tell you how we are trying to solve it. So what is the difference between machine learning and deep learning? Machine learning takes less time. Some algorithms are simple, but deep learning can take up to weeks and it needs GPUs. That's why NVIDIA is the highest running stock now. And it is impossible to know what is happening also. So there comes a black box. So whatever model they may be, and we are now going into AI version 4, where it would be the AI of things, AIoT. The most important thing is data collection, pre-processing, selecting the particular model, training the model, and then hyperparameter tuning so that hallucinations are less. So we hematologists have never been far behind. Okay, whatever CDSO fields and all. British Journal of Hematology in 2020 published this beautiful review article explaining what is supervised learning, what is unsupervised learning, and what is reinforcement learning. So imagine an intern, say 20, 30 years back, they were actually having supervised learning because there was someone to guide them. So the goal is to predict outcome based on a label training set. Whatever their teachers learned, they were teaching. So classic example is you can predict survival following allogenic hematopoietic stem cell transplantation. You give the model your data and it does it. Unsupervised learning, unfortunately, is a fact of the day today for the interns. So they go there, they might not have any help except their phones and computers. And with unlabeled data, they try to identify patterns and groupings. So the machine will try to identify clusters of similar gene expression profile among B-cell lymphoma samples, which maybe when we were taught about flow cytometry, we were not aware. So the machine can see something which we cannot. Reinforcement is the best way to teach your child, right? So you teach them something and then you reward them if they do a good work, and you might punish them or at least say, no, this is wrong. So example is you can propose optimal vasopressor administration for critically ill patients. So every time it changes, like how the dopamine should be given, how noradrenaline, and it's a dynamic system. So these are the three methods of learning. Whatever I told you about the foundational models, they are all unsupervised learning with a transformer model. If you want to read that article, this was published by the Google team. And the heading of this article, there were so many Indians there, Indian Americans, who said, attention is all it needs. That was a beautiful computer science article. And then you must have heard of these models because they are there in the articles. SVM, support vector machine, random forest, K nearest neighbor. And so in random forest, you have different decision trees, and then you do a voting, and then you take a final class. So we have understood only 10% of how our human brain works, and we are trying to copy it. So now, mimicking the human brain, we are trying to develop something called CNN, convolutional neural network, or graph. So graph is basically like a decision tree. Okay, you are sitting in a class and you feel that the teacher has copy pasted everything. So then you say, should I attend the rest of it? Or, oh no, there is something new. So all this get into there, and ultimately you take a decision. So let me tell you that those of us who came into medicine because we didn't like mathematics, medicine will be overwhelmed by mathematics. It is already being done because these are actually all mathematics and statistics, and your GPTs are basically statistics on steroids. So if you are predicting the next word, or if you're asking an answer to any question, don't think that it thinks like a human. It goes through enormous big data. I'll tell you how many data points, and sees what is the statistical probability of the next word coming in. That's why for it, language is not a problem, be it English, Tamil, Telugu, any dialect. Then we use certain feature normalization techniques so that there is less hallucination. So there have been two distinct eras of computer usage in training AI systems. Initially from 1960 till 2015, 16, it was going according to Moore's law. So Moore's law says that the technology is doubled every 2 years and the cost becomes half. It was following the Moore's law, but then now it is in a logarithmic scale. Okay, AlphaGo 0 and NMTs are all Google these things. But what you have to understand is that the capability of these machines, and mind you, we have not even entered quantum computing now. This is all basic computing using CPU and GPUs. We are already there, and we reached there in 2015, where the machines were better in identifying pictures and in identifying human voice. So they were doing a better job than us. If a human spoke to them, and if human spoke to a human, they were doing better than us, as you can see here. And it's already been 10 years. Okay. So the first large language model, large means it's clearly taking care of big data. And language is, as I told you, that it mimics a language. First was ELIZA, then LSTM, Stanford Core in natural language processing, Google Brain. But while they were sitting and they were developing this Google Transformer architecture, OpenAI came in and blasted them with GPT. So now you have GPT 5.2. Now, what is the amount of data size? Billions of parameters. Some of them do not reveal, some of them do reveal. So it was known that GPT-3 was using 175 billion parameters. Megatron Turing Natural Language Group were using 530 billion. But you would be, I think, reassured that when a baby is born, a human baby, it can analyze 100 trillion parameters. Okay. So even these models, maybe with quantum computing, they will reach that. They have not been able to reach what a human baby's brain is capable of. And using this, taking data from wherever you want, if you use Google LM Notebook, you can see that it can even learn from YouTube videos or your Facebook chats, and then it can do your sentiment analysis, question answers, and all those things. But if you look at the theory of mind test, the thinking test, there are actually basically two tests. One is the Turing test, which was proposed by Alan Turing, who said that a machine will pass a Turing test when a human will be talking and there's a wall. On one side is a machine, one side is a human. And if the human cannot differentiate between the machine and the human being, then the machine is capable of passing the Turing test. Let me tell you that most of the models have passed the Turing test in September 2024. So even the humans who participated in these trials said that the machine was more empathetic than the human. Don't get afraid. I'll tell you something else. So then OpenAI released its O1. It has thinking models and all, but everything for that is related to dollars. But you as a user should know how to decide which are the best language models, right? So I'm just giving you a link on Hugging Face where you have something called the Open Medical LM Leaderboard. If you have access to a model, you can then do a benchmarking, and that is how we are trying to understand the different models. So I always say that now we are in AD. We were in BC, that was before ChatGPT. AD is after DeepSeek. And 2 weeks back, DeepSeek's thinking model, when we compared it with certain benchmarking parameters, was doing better than most advanced versions of ChatGPT and Claude. Now, why AI in hematology, especially in hemato-oncology, right? Because it is one of the most data-intensive medical specialties. We all know that. It generates vast amounts of information from right from history to peripheral blood smears, flow cytometry, next-generation sequencing, multi-omic analysis, proteomic, and all that. Now, this wealth of data presents both opportunities and challenges for us, the modern clinicians. So, what actually happens is that we have inherent limitations, especially our colleagues who are in hematopathology and diagnostics. There can be cognitive fatigue during long microscopy sessions. There can be subjective interpretation variability between observers. If you look at who tries to standardize, even in myeloproliferative neoplasms, if you have 3 observers, there is discordance in more than 40% events. And there are time constraints. What kind of bioinformatic pipeline you're using and how you're interpreting the NGS. And these challenges become particularly acute when dealing with rare cell populations. We are doing single cell assays, right? So it's a lot of data from a single cell, or there are subtle morphological changes. Now, where does AI excel? It excels in pattern recognition, as I told you, even in an unsupervised manner, cellular morphology, immunophenotypic profiles, genomic, proteomic signatures. Also in high dimensional processing. So multi-parameter, multi-omic, which is beyond a single human brain's cognitive capacity. And it can do what we call as forecasting. So, now you have chat astros and all those things. So predictive analytics, advanced algorithms identifying prognostic biomarkers, treatment responses, disease trajectories. So you start from womb to tomb. And what we are telling here is it's no more metabolomics and all those things. What we are now proposing is exposomics. So exposomics means whatever external and internal environment you are being exposed to. So that definitely needs, but remember that AI augments rather than replaces clinicians. Technology serves as a powerful diagnostic adjunct, but it cannot replace our clinical judgment, which defines quality patient care. So, as I told you, hematologists were never behind. In 1980, we had image processing software, which is still used, automated blood cell morphology, cytogenetic studies, cytology. And then in the last part of the previous century, we had rule-based expert systems in lab medicine, flow cytometry gating. Then when this foundation model came, SVM's random forest gradient boosting, nonlinear biological data alongside NGS, and then deep learning revolution. So now they can outperform pathologists in classifying bone marrow aspirates and medical images, be it chest X-ray, CT, MRI. And today, these generative AI models can simulate new molecular structures, synthesize training data, generate explainable insights for precision medicine. But where is hematology? You look at this I generated in February 2026. Can you see where hematology is? You, you can see it, it is here. And this is where radiology is. Okay, let me remove radiology data. Now, yes, it is at par possibly with critical care and anesthesiology, but other than radiology, cardiovascular neurology are there. Mind you, these are all device, so we call them software as a device and they are approved by US FDA. Now, this did not come in a day, right? Because the digital renaissance started when we started digitizing images. So now you have something which is digital whole slide imaging with AI. So KI67, it's not about your human nature telling you, okay, this is high. Computational histopathology, including bone marrow aspirates. And then you can predict. Even there are PathChat and vision language models which can combine image analysis with the clinical dialogue. But that is where the problem is. Are we documenting the clinical dialogue? Are we taking a good history? If we do not give it, this machine will be as dumb as we have remained. So one model, PathChat, has achieved 89.5% diagnostic accuracy on expert tasks from histopathology. So obviously the resolution has improved, and that's why we have reached here. And then what we have done, and this is something which I think has a good future, you can now understand high-risk genetic markers not through DNA sequencing, but by letting AI look at your histopathology or your blood samples. It sounds fascinating. There might be a day when even you will not need a refined biopsy, but I'm not going into those details. Most important is you can now do quantification of the subjective things, and generative co-pilots are already there, like Vicho, Prov Gigapath, Conch, UNI, and you just ask your friend, the model, identify regions of tumor heterogeneity, suggest ancillary stains. It will do it. So, if you're looking at Richter's transformation, this is very useful. And then it is multimodal fusion. This obviously is already there. It starts from clinical variables, including all sorts of, even your scores, your blood sample reports, your clinical staging, and then your genomics, and then your histology and risk score, right? So there are so many scores there. And this, when you send it to the pharma industry and the pharma research labs, they can now develop precision drugs for this, like the merge framework. So you have a liberated pathologist. This is a comment from one of the pathologists in Mayo Clinic. He says, when we can't use the AI, when it's out of order, say for some reason, it's like we just want to leave the room, because traditional workflow was taking so much time and you are getting only 20% diagnosis. Now AI assisted, you are just doing 10% of the work, and 90% complex diagnosis integration is already being done. You are the human in the loop who then does it. And then you can scale it up. You have a central lab, and this is how US is doing it. So there are certain models. Obviously, they are expensive, but just as for drugs like microsatellite instability, MSIs, or homologous recombination deficiency, some of them have been made now reimbursement viable for even insurance companies. So you can even distinguish tumor ctDNA from chip, because as more and more chip data is coming in, people are getting more anxious. So these models can analyze more than 1 million cells per run, and MRD detection has now come to 10 to the power of -5, proceeding to 10 to the power of -6. So digital microscopy transformation, they mainly use CNNs, YOLO version 10 models, now 11.2 is there. So laboratories can do the initial run-up. They can also look at deep learning architectures for bone marrow pathology. Even in India, some of the labs are already using it. And emerging vision language models, so it's now not large language, but vision language models like CLIP and MedClip, it's the next frontier. Flow cytometry analysis, you'll be amazed to know that BD acquired, I think, 32 AI startups in the last 1.5 years, because otherwise they will not be able to sell their flow cytometers. So unsupervised clone discovery, automated gating protocols, MRD detection. Consistent, and you can read these articles. I'll just show you some of the images. So this is on the left, you see the manual gating. On the right is the automated gating. Now, for a person who is a clinical hematologist, I cannot even see a difference. And now my hematopathology colleagues are also agreeing. So it is revolutionizing cytogenetics karyotyping using CNN and other models. And you can have transformer-based karyotyping systems which have been taught on 50,000 annotated images. Now, the most important thing is who has annotated them. That is where we humans are required. And now liquid biopsy is meeting artificial intelligence. So you can enhance the signals because there are so low few signals, multimodal fusion, and it can predict relapses by recurrent neural networks 4 to 8 weeks earlier than conventional modeling. But it's 90% accuracy. We have to reach 99%. So from breast cancer, what they're doing is, this is not in hematology, obviously, but they are fusing the images with the molecular studies and trying to do as much precision targeting as possible. So in leukemia and lymphoma, we are integrating genomics, transcriptomics using, I told you about graph neural networks. There are graph attention networks, graph transformer networks across tumor types. And then we are doing single cell AI analysis, especially in AML, because that is the most difficult for us. So this is one article. This is more than 2 years old, but it explains how they are doing it, looking at gene expression, looking at the drugs, and trying to understand the patterns, which drug to use in which patients. Quantum machine learning, though quantum is not a so-called standard of computational care today, we already have models like QProteoML, which leverages quantum principal component analysis and quantum support vector machines to detect multiple myeloma early and also detect relapse in multiple myeloma quite early from proteomics. Now, every time I speak to a new audience, I ask this question: can you diagnose acute leukemias without using a microscope? So most of the time, only 5 to 8% say that, yes, you can also put it in the chat box, but this is also more than a year old. This was published in Lancet Digital Health, evaluation of a machine learning model based on laboratory parameters for prediction of acute leukemia subtypes. And you must be wondering, oh, then it would need a lot of genetic and all data. No, 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 no. It is possible in a district hospital. You just look at the MCV, you look at the PT, LDH, percentage monocyte count, mean corpuscular hemoglobin concentration, add age, lymphocyte count, absolute monocyte count, platelet, and fibrinogen, which is a bit difficult to do in a district hospital. These are the parameters. And what did they show? Using only those 10 routine parameters, they could do a rapid triage so that you can refer them to a tertiary center. And you know what was the kind of accuracy? 99.7% for APML, 99.5% for ALL, 98.8% for A. So this is what, and mind you, This is an open model which we can use today, and we can see whether it is working with our systems. Because if we are calibrating our automated biochemistry and cell counters well in districts, we can use this. So as I told you, there are several multimodal this, and Maria is one of them. Self-attention mechanisms and the speed. Diagnostic accuracy 96.85. MRD, I told you, 10 to the power of -5, and 4 to 8 weeks earlier detection. Stem cell identification from single cell, 99% accuracy. So you need data from clinical narratives. This is where we clinicians come in, from laboratory time series, digital pathology, flow cytometry, genomics, imaging, and put it all together. So real world impact has been, as I showed you for that AI PAL in peripheral hospitals, reference laboratory efficiency, it improves quality assurance, molecular laboratory interpretation, clinical decision support. Even today, most of us, when we get a very difficult case, we are taking help of LLMs, but now we are having focused medical LLMs also, and longitudinal monitoring of a patient's journey. So it has helped us in democratizing expertise, reducing diagnostic delays. For my pathology colleagues, there are certain tools. Some of you may have used it. I'll go through them rapidly. CellaVision, which is integrated in most of the cell counters which are available today. And this is another Scopio X100. So full field digital imaging. I was talking of, whole blood, whole slide imaging and blood samples, MDS diagnosis, AML blast count. And we have our own Indian sextuple, AI 100, which can be even used in a remote place, pre-classifies more than 30 cell types, even urine analysis. Now, while we criticize the black boxes, I myself, along with some of my colleagues in machine learning unit at ISI, we have also developed a pathologist-like explainable AI. So what is explainable AI? Where you know why the machine is answering like this. And that is what we are looking at. This is already published, and if any one of you want to use it, it looks at size, nuclear cytoplasmic ratio, granularity. A thalassemia patient who is now doing a PhD in digital health has developed a simple model which can differentiate nucleated RBCs, because that was his problem. He was splenectomized. So now with vibe coding, any person can do it. Tool number 3 is, as I told you, generative AI for decision support, ChatGPT, Claude, real world clinical, summarize the latest NCCN. And if you're using Google LM Notebook, you can only load the guidelines. It will not hallucinate because it will not go to the web even. But it has critical limitations. You have to give them proper sources and you have to recheck the references. The bottom line is that it is an excellent clinical adjunct for literature and research. I'll not be discussing research today. So are these H&E based computational models transforming? What is the answer today? And it seems to be doing in multiple cancers, including blood cancers. But then, as I was asked, is it a friend or foe? Well, because of its inherent design, it can become an enemy of yours. There are several paths by which it is generated: data, reasoning, deployment, operations, governance. I'll take them one at a time. Whatever I showed you of the accuracy of 99%, they are all retrospective promises. We have to do prospective trials. And the perspective is very important. A model developed in Stanford or Harvard will not work here. A commercial hospital group got IBM's Watson saying, now we have the best. It was a total failure, and more than 3 crore rupees went down the drain. And then real world hospital integration remains uneven. Yeah, I know Google works with Mayo Clinic, MD Anderson, and OpenAI is also working with such. But sometimes what happens is half of the hematologists feel unsure about the AI. So they dismiss up to 95% of AI generated alerts. So we also have to have that mindset. And mind you, AI does not fail randomly. It fails predictively. If you do not have good quality data, your training will be faulty. If it's a black box, then it has to be faulty if it is out of perspective and if it is not explainable. And then there can be deployment problems within the system. Workflow integration is a challenge. Most of the hospitals still scan, handwritten prescriptions. That was the same 2000 years ago. It is not machine readable, not machine understandable. And then there are regulatory and ethical hurdles. But for us, it is a real problem because there is a scarcity constraint. Most of the data are from US and Europe. So there is a class imbalance and rare patients are rarely there. So again, you need your human cognitive function. The black box is there in all I've mentioned, be it OpenAI, be it Anthropic, be it Google, be it Perplexity. Our goal is explainable AI. And that is why I showed you that, even when you're looking at images, genomics, or CBCs, it should explain why it thinks that there is a 92% chance of it being malignant. Deployment. The staining quality, that can change everything. If you have trained them on what is there in the public domain, they are so nice. But if your slides are not slain properly, they will be falsely marked as malignant. So the lab is homogeneous, heavily curated and cleaned. Real world is heterogeneous, varied coding. You have outdated laboratory information system and electronic health records, and you do not have like prospective clinical trials and continuous monitoring. There's a 5% error rate, which creates catastrophic alert fatigue because we have not been able to cross 95%. So there are a lot of computational constraints, interoperability, governance-wise, and then you have the DPDP Act, GDPR, HIPAA. I'm not going into the details, but if you get into this vicious cycle, if you're not sharing your data, first of all, the data should not be leaked. It should be anonymous. So this causes severe data scarcity. Models are forced to train on narrow single institution data, creating algorithmic bias. Hello, আমি একটা lecture দিচ্ছি একটু পরে please. Sorry about that. Narrow training ruins the generalizability, and then real world American models for you, and you get fatigue and loss of trust. So now, why is it not moving? Just a second. Let me see. Next. Yeah. So what is federated learning? Federated learning is just as your car contributes to Google Maps, right? Your car is not identified, but if you're facing a traffic jam, it is seen there. So each institution should try to contribute in a proper manner where individual patients can never be identified. And you have initiatives like Genomed for AOL and Synthema, which leverage federated learning, and that is the way forward. Architectural shift has to be there with explainable AI. We have to navigate the black box. So data set bias, generalizability, black box, over-reliance. And I don't know how many of you are already suffering from this disease. If you've heard of it, please let me know. It is called artificial intelligence induced cognitive atrophy. Okay. So if you're using your brain less, you will suffer. So if I look at a hematopathologist and a clinical hematologist, none of them will be replaced. The pathologist will be the diagnostic integrator. They will be the critical evaluation and interdisciplinary collaboration. We have to identify the failure. You have to identify how it is done, how it is validated. Because remember, in India, if something goes wrong, you are going to be sued and not the manufacturer of the model. So federated learning continuous model calibration by experts in the domain, explainability tools, look at the good practices, the DPDP Act, integrate into the system so that otherwise it increases your work, and what we call as human in the loop. So it is neither a friend nor a foe. It is 50 shades of gray, right? How you use it, how you understand it, that is most important. There has to be data equity, explainability, and prospective validation. We must re-architect the AI pipeline from a black box oracle into a transparent, explainable partner. So in the next decade, we will be doing a lot of clinical validation and deployment. National Institute of Digital Health, which is under ICMR, is trying standardization and scaling, and then precision medicine. You'll be able to see it hopefully by 2030 or even earlier. But for that, you have to maintain good data. You have to be working. Don't think that the engineers are solving your problems. Multimodal integration, thoughtful approaches. But the most important person in the room is the AI literate hematologist. I hope I have been able to make you literate. If you want to read, you can read this book, which is a chapter by me on hemato-oncology. We also have a certificate course for lab professionals, for clinicians. Remember, don't leave it to others. If you leave it to the big tech companies, they will be joining hands with the corporate hospitals so that they can increase the profits and you will be just a cog in the wheel. So let us have a fair play. These are my coordinates on the QR code. Thanks for this opportunity, and I'll stop sharing.
Thank you. So we have some questions in the chat box and we have some raised hand signs.
Yeah, Dr. Manoj.
Dr. Manoj, let's start the ball rolling.
Thank you, sir. It was a wonderful, wonderful presentation, and I get reminded of two interesting quotes: uh, "Garbage in, garbage out;
Yes.
gold in, jewelry out."
Yes, but in healthcare, it is
Yeah.
garbage in, harm out. That is an even bigger problem.
Thank you for the modification. And I also heard a very interesting quote when I was going for a talk on AI only, and that was like, uh, "Your job, people will not lose job because of AI. They will AI enabled people will take your job." So that's
Yeah,
something an interesting point. I have a
yeah,
very practical question, and there are two, sir, and
yeah,
you
yeah,
can choose to answer them.
yeah, yeah.
How do you respond to a patient or a caregiver who comes with bundles of AI integrating all the softwares together? One.
Yes,
And my second question is more from a clinician's perspective, that what are the tools which is a must to have, and what are the tools which is good to have? Because AI is a vast field, sir. So out of this vast field, what is that which I must do it? I mean, it should be there in the textbook as a subject. And what is that which is good to have? So two questions, sir.
Okay, I'll answer your first question first. So I appreciate when I get a patient. See, this is nothing new. They were Googling their symptoms earlier also, right? Now they bring out printouts from, and even OpenAI has a health thing and Gemini has. So then they come up with all that. Most of them are smart enough because they must be knowing that sometimes, I'm a bit more sarcastic. They will only start revealing those after I discuss. And almost 90% of the time, they say, sir, what you told me, ChatGPT is also saying the same thing. I said, well, I'm fortunate that I'm being validated by ChatGPT, but let me tell you that ChatGPT does not understand you fully and it does not understand the context, and it was not built to do what you're trying to do with it. They might understand what I'm saying, they might not understand, but I tell them clearly, this is my opinion. It is better if you want to validate, you get it validated from someone like Dr. Agarwal rather than from ChatGPT. Because I showed you what the problems are in developing it. but I never get angry. And we shouldn't get angry because I myself and even my secretaries who are not even graduates, they can generate excellent SOAP notes from 70 to 80 documents brought by our patients because it's not in an organized manner. So when you get a organized SOAP note, most of them handwritten, you have to double check obviously because sometimes our handwritings are very bad. That is one aspect. Now you tell me what you should have. Let me tell you, even if you do not want to have it, it is there in your phone, it is there in your laptop, it is coming every day. And whatever I saw of Sundar talking on Google I/O 2 days back, it will be more there. It is all about how much you are willing to pay. So now we are thinking of whether we should take it from a particular company or we should take from aggregators who give you several models. So let me tell you, to tackle misinformation and hallucination, what I do is I take output from one model, give it to another model and say, is it true? And invariably, to impress, it will say, no, it is not true. And it will give me some points. And then I debate with another. But, you're using tokens there. Medical based AIs, and especially for research, you have now Skyspace and PaperPal, all those things, they are very good. But the only problem is if an undergraduate student is using it without knowing the problems, then they will do more harm. But if a professor is using it who already has domain knowledge, it will do more good. So both are Gigo and Giho. Now you decide what to do. Any large language model, but let me tell you, in India, we have our own medical consortium, and we are now trying to build a conductor of an orchestra with small language models. Because there is one particular radiology model which is very good at detecting lung nodules, which whether they're malignant or not. There is another model which can detect from a CT whether there is a stroke or not. So you can use it according to what you want. And remember, you have to be a Zubin Mehta. You'll have very good musicians all around you, but ultimately you are the conductor of that orchestra.
Thank you. Thank you. There are two questions in the chat box. Dr. Ankita Nayak has asked, are there any pointers to write a good AI prompt? How do we learn writing contextual summaries for slides as well as the clinical cases?
Yeah, that's a very good question. So, now people are saying that if you do prompt engineering, you'll be great. Let me tell you, the models are becoming smarter day by day. So, at this point of time, if your grasp over the English language is good, you can be a good prompter. But remember, never accept the first output. You have to reiterate. And what is the best will be decided by you when you start using it regularly. There is no way. There are so many YouTube influencers and others teaching you prompting. And let me tell you, now there are AI tools which actually modify your prompts. Even simple tools like Grammarly or Quillbot, which were correcting our grammar, they are even correcting our prompts. But the way it is going, it is all about, maybe in Bengali, Tamil, or Telugu, it will take some time. But in English, if you have a good vocabulary and if you understand what you want to do, and if you don't get a good output, tell it, no, this is very bad. I want it in this manner. It will again do it. It will again do it. Sometimes it may take more time, but all the time saving will still be there, because if you had to do it manually, sometimes it is beyond your human capabilities. So play with it. There are some good books. There is actually a prompt engineering book for clinicians by Dr. Srivastava. I have purchased it. I have gone only through 2 chapters, but the logic presented there is good. But once you start playing with all these models, you'll understand.
Thank you. Dr. Durja Shon, very thought-provoking talk.
Thank you.
Please explain a bit about how the process of prediction of molecular characteristics from histological characteristics developed by different platforms was standardized and validated? How is such AI output validated in the real world practice for confident application?
Yeah, that's a very good question. So first, let me tell you, even in the field of molecular biology, for bioinformaticians, they do not rely on one model. There was a beautiful review article, I did not show it here. They says that you at least choose three models. Even, so our greatest problem is you send for NGS and then you get variant of uncertain significance. Patient does not know what to do with, you also do not know what to do with it, right? So those are being validated just like a librarian. So they are giving it to one model and saying, what is the percentage of pathogenicity here? Then it gives to another model, which does it in a different way. It gives it. Then there are three. Why three or five? Just as in voting, you have to have odd numbers, because if two are diametrically opposite, you cannot accept. And for that histopathology one, that is through multimodal AI. So they have those histopathology slides, they have the genomic reports, they're trying to identify patterns within the histopathology, and they are validating it. FDA has approved recently, I think, one or two in prosthetic CA. But it will take some time to come into the domain of hematopathology because lymphoma is more complicated.
Thank you. We'll take one last question from Dr. Babita Sodi.
Yeah.
Good evening, sir. First of all, thanks, Dr. Agarwal, sir, for having me on this platform. And, sir, very well, thanks for the excellent talk, Dr. Prantar Chakravarti. You have very well explained from the basics to the molecular and to what the AI is today. Sir, my question is very basic and very this thing that you have very well said that it is neither a friend nor a foe. But my question is that what is the protocol that if, especially speaking, if it in the hematology, hemato-oncology, what can be the protocol so that it is more a friend than a foe, like we can productively use it in our practice?
Yeah. So to have it as a friend, you have to have good domain knowledge. That is most important. Because if you do not have good domain knowledge, it will mislead you. So actually, it is a friend. Think of the practitioners who are there alone. For academicians, they at least have some postgraduate or postdoctoral trainees with whom they can discuss. Think of a person who is sitting in a district, looking at a case and thinks that this might be this. For them, they already have the domain knowledge. They have suspected it. They can now load the clinical characteristics and reports and see what the AI tells them. So then it becomes a friend. Similarly, for a pathologist, they have looked at it, they have looked at the data, and then they say, okay, what is your opinion? So it is a friend in that manner. But as I tell you, that knowledge transfer is very difficult. So the people who will be mostly benefited are people who have good domain knowledge.
So then at the same very time, then what is the protocol if so that it doesn't rule over the human mindset? That is the fear
No, it cannot rule over the human
the
mindset, because ultimately, be it a report or a prescription, you're going to sign it.
right.
Right? And I told you sometimes, see, there was an interesting study. I'll complete it in 30 seconds. So what was compared? AI alone, AI with a human alone. And it was seen AI alone did better than human with AI. So we said, what is happening? Then we understood that when AI and humans were there, humans were not accepting what the AI was saying. So that's why, in terms of correct prediction, AI scored. But that is not the real life truth.
Thank you, Pranka.
Thank you, sir.
This was
Thank
lovely. I think you have made many people stimulated in this branch, and I think they will have a lot of food for thought now. Thank you for spending your time with us. We move on to the second web lecture this evening, and it's my pleasure to introduce Dr. Gaurav Dikshit from Gurgaon. He's head Department of Hemato-Oncology and Bone Marrow Transplantation, Artemis Hospital, Gurgaon. He's a well-known BMT specialist and hemato-oncologist in this country, currently serving as the unit head of hemato-oncology in that institute. He has independently performed or been involved in over 500 bone marrow transplants. He's also credited for carrying out the first bone marrow transplant in Kenya. He completed his MBBS and MD in general medicine from PGIMS Rohtak. He did DM in clinical hematology from CMC Vellore after 4 years each at Max Hospital, Shalimar Bagh, and Action Cancer Hospital. He joined Artemis Hospital. He played a key role in both those institutions in establishing the BMT program. Apart from his excellent scientific knowledge, the clinical aptitude, he's also known for his flexible approach. He always treats his patients in accordance with established worldwide norms and is well acquainted with most recent advancements in the field of hematology. The Mayo Clinic in the United States of America granted him a professional certificate in myeloma way back in 2020. Today, he's going to tell us all about changing treatment paradigms in chronic lymphocytic leukemia, from continuous to now time-limited therapies. I'll stop here and over to him. Yeah, Gaurav.
Thank you very much, sir, for a very generous introduction. Mine would be a more conventional and a bit boring talk as compared to Dr. Prantar's, and I must compliment that his talk was actually wonderful. It was thoughtful, and probably mine would be focusing more on the CLL, which all of us are dealing on daily routine. Is my slide visible? I hope it's visible.
Yes, it's visible. You can just convert into, first class.
Okay, so I'll be talking about changing treatment paradigm of CLL from continuous to time-limited therapies. And on my way, one second. I will be discussing about evolution of therapies in CLL, then role of chemoimmunotherapy and continuous BTK inhibitor-based therapy, then the latest guidelines on CLL management, combination therapies with BCL2 inhibitors and anti-CD22 based therapies, then emerging fixed dose duration combination. Then I will talk about treatment initiation and dose modification strategy with the BCL2 inhibitors. So this is the evolution of CLL treatment and key treatment milestones. So initially, our main goal was to alleviate symptoms, reduce lymphadenopathy, improve blood counts, and cyclophosphamide, chlorambucil were the initial agents which were used. And then in 1990s, focus changed to improving survival with the use of multiple chemotherapy agents like fludarabine, cyclophosphamide, and rituximab also was introduced during this time. And now our focus has changed to reducing toxicity and improving outcomes in more and more patients. And there are various trials which were conducted over last many years, which we are going to discuss in our further slides, which has helped in modifying the treatment in a great way. First, I will talk about the role of chemoimmunotherapy in current era, and I'm sure most of us have used FCR and BR at some point of time in their careers, especially someone who is practicing from last, say, 10 to 20 years. It was very commonly used, and BR especially is one of the regimens that still many of us are using because of various reasons, insurance and limited time and various other things. So this study was done by Philip A. Thompson, published in Blood a few years back. Very long-term follow-up with frontline FCR in CLL. And it showed that median follow-up 15-year overall survival was about 63% in IGHV mutated patients versus 32% in IGHV unmutated CLL patients. which was quite comparable to age and sex matched general population. And the median PFS was 14.6 years in IGHV mutated versus 4.2 years in IGHV unmutated population. One category of patients in which it is still being used is and it can still be used is the IGHV mutated patient population. However, FCR had had inferior PFS rate in patients who are MRD positive, mutated IHV, and there was a high incidence of secondary malignancy, as we can see from this slide. After 19 years follow-up, median PFS was 14 years in mutated IGHV. Then after 4 years, it was 4 years in unmutated IGHV. Grade 3 neutropenia is another issue which is seen in about 50% of patients. Infection is very common. Then secondary malignancies, solid tumors are seen in 10 to 14% of patients. Even few patients land up in AML or MDS. So this is another issue while using this combination. Second important regimen that we are using or we have used is the BR regimen. And there is still PFS benefit with this regimen. And this is a slide from Sequoia trial, which compared BR with zanubrutinib, which we are going to discuss in further slides. And it shows that in patients who have mutated IGHV, median PFS is about 5 years. However, patients who do not have this or who have unmutated IGHV, median PFS is less than 3 years. So again, pointing that probably the only place where this is beneficial, chemotherapy is beneficial nowadays, is the mutated IGHV patients, where it has a reasonably good PFS rate. Another problem is that there is evolution of chromosomal aberrations during treatment, and this slide shows that when we are using chemoimmunotherapy, the chance of complex serotype increases on the time of progression. We can see this first bar graph, and in patients who are on limited time duration therapy, the chance of developing various karyotype evolution is lesser as compared to the chemotherapy arm, and same is with deletion 17p. And even the mean number of chromosomal aberrations were much more in CIT group as compared to the limited duration group. So there is increase in chromosomal aberrations, whereas venetoclax treatment is probably something which bypasses this issue, this problem. Now, what is the role of continuous BTK inhibitor therapy in current era? And we all are using this now. It started with the ibrutinib, and this is CLL17 study design. Patients who were previously untreated with the CLL, they were randomized 1:1:1 in ibrutinib arm. Second arm was ven and obinutuzumab, then ven and ibrutinib arm. There was about 1,000 patients, and median observation time was about 3 years. So standard drug dosing was used in these 3 arms. So this trial showed that there was non-inferiority of fixed duration when obinutuzumab or when ibrutinib as compared to continuous ibrutinib therapy in first-line CLL patients. On the left side is the patient characteristics in this trial, and after median follow-up of about 34 months, undetectable MRD was something which was not seen in continuous ibrutinib arm, and on a fixed duration when obinutuzumab 73% achieved this MRD negative state, which was even more than the venetoclax and ibrutinib arm. PFS rates were not much different, about 80% in these 3 arms. In unmutated IGHV, again, it was almost the same, more than 70%. So it has actually bridged the outcomes between these two groups, mutated versus unmutated IGHV arm. And talking about 17p deletion or TP53 mutated patients, continuous ibrutinib was slightly better with a better PFS of around 80% as compared to 60 and 70% in other two arms. Infections are a problem, more so with the venetoclax and obinutuzumab. However, any grade infections were almost the same in these three arms. Grade 3 or more infections were more in venetoclax and obinutuzumab arm. So PFS rates were quite comparable in these three groups, except for probably deletion 17p patients. This slide combines various trials in continuous BTK inhibitor therapy. And on the first one is the RESONATE-2 trial, which compared ibrutinib with chlorambucil, and a 9-year PFS rate was 49.7% versus 4.4% respectively. And median PFS was about 9 years and 1.3 years. So there was actually no comparison between these two. In the second one, it's the ELEVATE-TN trial, which shows the efficacy of acalabrutinib. And it compared acalabrutinib with the obinutuzumab and chlorambucil. And 6-year PFS rates were 62% versus 17%. Median PFS was not reached in acala arm, and in chlorambucil obinutuzumab arm, it was about 28 months. Showing a wide separation of curves. And in Sequoia trial, which compared the zanubrutinib versus BR, it's 82.4% versus 50% 3.5-year PFS rate. Again, showing the efficacy of continuous therapy as compared to the standard therapies. So, however, all of us are using it now, and we are facing few issues when using these drugs. First one is the cardiac problem, which patients have problems of atrial fibrillation. Although this is more common with the patients who have underlying cardiac disorders or who are having COPD. Hypertension is another common issue. Acalabrutinib had 11% versus 23%. Then bleeding is a problem, 40% versus 52%. So we always have to kind of give a break or stop BTK inhibitors before doing any procedure. Otherwise, patients may land up in bleeding. Infections, sometimes they become a problem, and grade 3 or more adverse events are seen in quite a bit of patients in zanubrutinib arm versus acalabrutinib arm. Second, malignancies can also be a problem with long-term use of these agents. Then adverse events continue over time with indefinite BTK inhibitors, and we can see from this chart that the first one is from RESONATE-2 trial. Hypertension kind of persisted, and usually we expect that with continuous use of one agent, side effects should reduce over time, but it's not always the case, and the problems, it tends to persist. Diarrhea incidence is something which comes down with time, as do headache and body aches, but hypertension and cardiac manifestation, they continue to persist with use of BTK inhibitors. So all of this leads to high treatment discontinuation rates with the BTK inhibitors, and various trials have shown that 21% of a patient actually discontinued acalabrutinib in 2 years, 30% discontinued in 4 years, 50% discontinued in 6 years. 15% of patients actually discontinued zanubrutinib in 2 years, and more than twice in 5 years. So again, overall median duration of treatment ranges about 5 to 9 months, which is a bit less. And among 250 patients treated in one trial with first-line BTK inhibitor therapy, 18-month time to next treatment or death was about 70%. So these are the data which shows that Probably with the use of the continuous use of these drugs, side effects tend to set in, and it leads to high discontinuation rate. And it's a problem with our patients also, because they tend to ask again and again, कि डॉक्टर साहब कब तक दवाई चलेगी, and when are you going to stop this, which we don't have the answer. And with ibrutinib also, many of my patients, they actually reduce the dosing by themselves, reduce to 2 tablets, then 1 tablet. So this is another problem with our patients. Bigger problem is the emergence of resistant mutations with continuous use of these drugs. And on the left side is the pie chart summary, which reported incidence of BTK inhibitors. The incidence of various mutations. And it shows that at the time of disease progression, there are mutations in BTK in about more than 1/3 of patients, and PLCG2 only in about another 10-15% of patients. And more than 50% of patients have BTK or PLCG2 mutation combined. PLCG2 is a protein which comes one level down the BTK, and the problem is that if patient has this mutation, then even the recent agent, which is pallobrutinib, will not work. So they will be resistant to all the available drugs, and we have to use some other therapy in these patients. In patients who have this wild type of mutation, we can use some different agent and see if it works. And this is the spectrum of BTK mutations seen. Most common is this C481S, which is seen in most of the patients. And pallobrutinib is effective against these patients. But in patients who have both these mutations, it becomes a challenge, and we have to change the line of management. So what are the pros and cons of using this? Pros are it's easy to start. 1 month of therapy hardly cost about 25,000 rupees, with aclabrutinib generic being available. There is a good long-term efficacy data, as we have discussed in various. And in patients who have a deletion 17p or TP53 mutated state, it leads to prolonged PFS rates, and the toxicity profile is now well known, and all of us have good experience with using these drugs, and we know how to manage this. Problem is that there are low MRD negative rates, low CR rates. It's an indefinite treatment, and as we have discussed that there is high rate of discontinuation of treatment. There is problem with long-term adherence. There is bleeding risk, and patients again who require surgical procedures, who have comorbidities, we need to stop this. Then there is cardiovascular risk with hypertension and AF. And lastly, indefinite therapy increases the risk of target mutations and cross resistance to other BTK inhibitors. So if patients develop resistance or they progress on BTK inhibitors, then it is unlikely that they are going to be responding to BTK inhibitors, another BTK inhibitor immediately. So maybe after some drug-free period, they may be effective, but not immediately in most of the cases. These are the ESMO guidelines preferring the time-limited therapies for CLL patients without TP53 aberration, irrespective of age. And on the left side is IGHV mutated patients with no TP53 or deletion 17p. Patients who are fit, they are offered, ESMO is advocating when obinutuzumab or when ibrutinib in unfit patients, when obinutuzumab is a fairly good option. And same options are there with the IGHV unmutated patients with no TP53 mutation. Fixed duration or time-limited therapies are preferred. And in patients who had TP53 mutated states, data is better with the continuous therapy with aclabrutinib, zanubrutinib, or ibrutinib. but in special patient categories, we can use any of the therapies that we have discussed. And so toxicity and retreatment options should be discussed when we are offering therapy, because retreatment is easier in time-limited treatments and therapies. This is the NCCN guidelines, and both time-limited and continuous treatment options have the same level of recommendation in first-line CLL, irrespective of mutations and cytogenetics. And it does not prefer one over the another, whereas in ESMO, there was slight preference given to one over the another in various patient population, as we have discussed. Chemoimmunotherapy is not commonly used is not commonly recommended, and it says that bendamustine, rituximab, or FCR can be considered only in patients when these routine therapies or the standard therapies are not available. So this is what the NCCN guideline says. Now talking about the fixed duration treatment option in first line CLL. First is the ven and obinutuzumab, BCL2 inhibitors and anti-CD20 inhibitors. Then BCL2 and BTK inhibitors, which includes ven plus acala plus minus obinutuzumab, then ven plus ibrutinib. All these therapies are 14 to 15 months therapy, when Gazyva is 1 year therapy. Data is coming up about MRD guided ven ibrutinib, and fixed duration therapy is FCR and BR also, which is fixed 6 months. It is used sometimes. Now we'll talk about combination of ven and anti-CD20, which is the CLL14 study. And when obinutuzumab was studied as a 1 year fixed treatment duration regimen in first line CLL or CLL14 study, it was a multinational phase 3 open label study, which compared venetoclax and obinutuzumab versus chlorambucil and obinutuzumab. Obinutuzumab was started first at day 1815, and on day 22, venetoclax was introduced, and it was introduced in a gradual manner, where starting from 20 milligram to reduce the risk of tumor lysis. Primary endpoint was PFS and ORR rates, MRD rates, OS, and MRD was a secondary efficacy endpoint, and it was not a determinant to treatment duration. And but it was seen that when obinutuzumab induced high rates of deep responses, including undetectable MRD, the upper chart shows undetectable MRD in peripheral blood at end of the treatment. It was 76% versus the other arm, where it was 35% in bone marrow. 57% of patients had MRD negative state, as compared to 17% in the other arm. So significantly high MRD rates were observed in venetoclax and obinutuzumab as compared to chlorambucil and Gazyva at the end of treatment. Talking about results with when obinutuzumab fixed treatment duration treatment, it was 1 year treatment. PFS benefit, it stayed beyond the completion of treatment, and investigator assessed PFS at 6 years was 53% versus 21.7%. Median PFS was 76 versus 36.4%, almost the double. And PFS benefit was sustained 5 years after completing ven and Gazyva, with 60% reduction in risk of progressive disease or death, as compared to chlorambucil and Gazyva. So it shows very good PFS rates in the whole group. Talking about specific subgroups in patients with the mutated IGHV, median PFS was not reached in ven O arm versus 62.2 months in the chlorambucil obinutuzumab arm, and PFS benefit was sustained even after 5 years of completing ven and Gazyva. in patients who had mutated IGHV status, showing very good separation of curves. In patients who had unmutated IGHV, PFS at 76.4 months showed median PFS of 64.8 months versus 27 months approximately in the other arm. And all patients were off treatment for more than 5 years in this study. And PFS benefit was sustained for 5 years or more in this slightly difficult to treat subgroup as compared to the mutated IGHV status. In patients who have TP53 mutations, PFS rates were like median PFS was 52 months versus 21 months, and it was sustained benefit. However, the curves, they started to merge at the end of treatment, and probably showing that fixed duration therapies at some point of time they may require a retreatment, whether you use one regimen or the other regimen, and they may require something which is more sustained. So there was a prolonged treatment-free interval, and when obinutuzumab group, 65% of patients did not need second therapy even after 5 years of stopping first-line treatment. And this is something which is very important for our patients. We can tell them that probably if you are using this fixed duration treatment, you are not going to require another therapy for more than 5 years. And a median time to next treatment was not reached in when OARM versus 52 months in obinutuzumab and chlorambucil arm. So, and the risk of starting new treatment was reduced by more than half in patients with ven-O versus O-chlorambucil. OS rates were 78 versus about 70% at 6-year estimate. There were slightly more number of deaths in chlorambucil arm, 26 versus 9. And however, the OS rates were still immature at the time of data analysis. Safety profile sometimes is a problem with venetoclax and obinutuzumab. And we know that neutropenia is something which all of our colleagues and are scared about. More than 50% of the patients had neutropenia at some point of time during the treatment, and 4% of patients had febrile neutropenia also. Patients had pneumonia also, and second primary malignancies, it was seen in about 30 or about 15% of patients in one arm versus 18 or 8.4% patients in chlorambucil arm. Second primary malignancies and infections are probably two things which we should be worried about in these treatment arms. And TLS was not a major problem. It occurred in few patients and it was well managed. However, there was no statistical difference in cumulative incidence of second primary malignancies between the two arms. Talking about the pros and cons of these combination therapies, pro is like it's a finite therapy. It has got less long-term toxicities, and there is less concern of long-term adherence. We are giving therapy for 1 year and we are stopping. And then other cardiac risks like arrhythmias, hypertensions are probably not a major issue with these agents. Bleeding risk is also less. MRD rates are more, and it actually gives patients more free time from therapy, and there is a possibility of functional cure also in good risk patients. Then there is less chance of developing mutations. Problem is again the TLS sometimes happens, neutropenia, infection risk, second primary malignancies. These are the things that are probably worth wondering about. Then in this part of my talk, I'll be talking about emerging fixed duration therapy options. One of the options which we are very commonly using nowadays in India is the venetoclax and acalabrutinib option, because it kind of it's a kind of fixed duration therapy, and with very good response rates, easier to give oral therapy, and it can be managed on OPD basis if tumor lysis can be managed in a proper way. And they are both these therapies, BTK inhibitors and BCL2 inhibitors, are synergistic, and they have got complementary anti-tumor activity in CLL, and safety profiles are not overlapping. BCR pathway is a very important pathway in cancer cells, and BTK inhibitor actually mobilizes CLL cells in the blood, and venetoclax depletes CLL from circulation, lymph nodes, and bone marrow. So we have seen that whenever we are introducing acalabrutinib or ibrutinib, there is increase in counts. That is probably because of the mobilization of CLL cells in the blood. And at that point of time, venetoclax takes action and deletes CLL from the circulation, lymph nodes, and bone marrow. BTK inhibitors inhibition also stops proliferation of CLL cells, and it thus promotes anti-leukemic effect of venetoclax on resting cell population. So in many ways, these two actions are synergistic, and this shows in this Amplify trial, which is combination. And in this trial, first line fixed duration venacella was studied, and patients with therapy naive CLL, about 900 patients, they were given venacalabrutinib or venacalabrutinib and obinutuzumab, or in arm C there was 290 patients FCR or BR, and the primary endpoints were the standard PFS and OS. Median age in whole group was 61 years with good ECOG. And these are the key characteristics which are fairly well balanced. High risk features were seen in 17.6% patient had deletion 11q. Then unmuted IGHV was also seen in about 58% of patients. So these are the disease characteristics of patients. In mutated IGHV group, there was no PFS difference between whether you use doublet therapy or triplet therapy, and 36-month PFS rates were 86% versus 84% versus 80% in venacalabrutinib versus venacalabrutinib obinutuzumab arm versus chemotherapy arm. And for patients with mutated IGHV, when acalabrutinib and venacalabrutinib obinutuzumab both had numerically higher 36-month PFS, but it was not statistically significant. However, in other unmutated group, a benefit was seen in patients who received venacalabrutinib and obinutuzumab, and 36-month PFS was 82.8%, and in other arms, venacala, it was about 70%, and in chemoimmunotherapy arm, it was about 56-57%. And for patients with unmutated IGHV, venacala and venacalabrutinib had longer median PFS than FCR and BR. So in this high-risk subgroup, probably it is better to use the combination therapies, whether we are using obinutuzumab or not. This slide shows a safety profile at 40.8 months, and on the left side, venacala arm, the routine problems with the cardiac issues, hypertension, it is seen, but not in very high percentage of patients. Hypertension was seen in 4.1 versus 3.9 in these two arms. Hemorrhage incidence was again very less. Neutropenia was a problem, and grade 3 or more neutropenia was seen in 33% patients in venacalabrutinib arm versus 46% patients in venacalabrutinib obinutuzumab arm. In FCR and BR, it is seen in about 50% of patients, and in FCR especially, it's a problem, and sometimes it is prolonged in the BR group also. So neutropenia is a problem with all the therapies that were compared. Infection rates were also about 12% grade 3 or more in ven-acelairon arm versus 23% in ven-acelairon and obinutuzumab arm versus about 10% in the chemotherapy arm. Now, this slide compares long-term PFS data of targeted therapy options in mutated IGHV patients, and this is a compilation of various studies. And in ibrutinib, suppose we are using ibrutinib, then from Resonate 2 trial, the 7-year PFS was 68%. While using acalabrutinib in Elevate TN trial, 6-year PFS was about 70%, and zanubrutinib Sequoia trial, 5-year PFS was about 80%. So a good PFS was seen in this group, and in combination therapy group with the ven plus obin, various trials were CLL14, CLL13, and it was a fixed 1-year therapy. And 6-year PFS was more than 70% in CLL14 arm versus more than 90% PFS was seen in CLL13 study. So both the therapies are quite effective. And again, it depends upon how we discuss with our patients and what kind of finances they have, how long they want to continue. So it comes at that point ultimately. And then the recent Amplify trial, very popular in India, ven plus acalabrutinib and ven plus acala plus obin. Treatment duration is 14 months, 3-year PFS is 86 versus 83%. So probably it will take some more time to mature, and it's going to be the frontline therapy in our patients. Now talking about long-term PFS data of targeted therapy options in unmutated IGHV patients. In Resonate 2 trial with ibrutinib, it was 58% in unmutated IGHV group. In Elevate TN trial, it was about 60%. With zanubrutinib Sequoia trial, it was more than 70%. And in ven-obin fixed duration combinations, PFS rates were about 40% to 60%. So in this subgroup, probably the continuous therapies had slightly better PFS rates as compared to the fixed duration therapies, if we see various data combined. Now, this is a slide which may help in taking a informed decision. And if we have a CLL patient who has IGHV mutated, then probably we can use all the treatment options, even the chemoimmunotherapy option. It has good response rates. But venetoclax plus obinutuzumab, ven plus ibrutinib, these are slightly preferred because of their fixed duration. PFS rates are almost similar, more than 85%. In second subset of unmutated group, IGHV group, it is better to use continuous therapies with acala and zanubrutinib. And in patients who have some cardiac comorbidities, we can always use the fixed duration regimen options. In TP53 patients, there is slightly better data with the continuous therapies, acalabrutinib and zanubrutinib, ibrutinib, as compared to the fixed duration therapies. In bulky disease, we can use any of the approved indications. Then again, the patient profile comes into picture, and suppose if there is a patient with the cardiac comorbidities, then it's better to use ven plus Gazyva. So it has to be tailored according to the patient. Last column is patient priorities and preferences. It ultimately comes down to this. And previously, it's very difficult to convince our patients to take fixed duration therapy, because acalabrutinib is cheap and it's easily available, patients are not easily convinced about taking hefty or expensive therapy upfront. So most of them, they end up taking continuous duration acalabrutinib therapies. So this is an issue with our patients. So, and this slide shows the TLS prophylaxis. I won't go too much into detail of this slide because all of us know this. If patients have high tumor burden, lymph node size of more than 10 centimeter, then the recommendation is actually to give the first dose of 20 milligram and 50 milligram venetoclax at the hospital to see that they don't develop tumor lysis, and outpatient can be monitored. Patients can be monitored in outpatient basis in the other doses and in various time intervals. So this was one point which I wanted to highlight, that recommendation is that when there is high tumor burden patient, then we should at least admit our patients for a day when you are starting with the venetoclax use in patients of like when we are starting 20 milligram and 50 milligram dose. Then the when dosing has to be modified with toxicities, and suppose we have a patient who is at risk of TLS or who develops TLS, then we withhold the next dose and we restart the same dose if it's the first episode, and if it is recurrent, then venetoclax needs to be started at a reduced dose, which is this chart. And if suppose earlier dose is 400 mg, we go down by 100 mg to 300 mg, and we always get one step down. If patient develops repeated complications, repeated tumor lysis, same is with non-hematological toxicities. Then again, if it is first time, then we can resume venetoclax in same dose. However, if it's a recurrent toxicity, then it should be given at a lower dosing. Patients who develop neutropenia, we can manage them with GCSF first. However, if we can also, if it is recurrent or problematic, then dose should be reduced according to this chart. So this is one helpful chart which may help us in managing our patients who develop problems or complications on venetoclax. So with that, I would like to finish my talk, and thank you very much for patient listening. I hand over the mic stage to Agrawal sir.
Thank you, Gaurav. It was complete coverage of the subject, which you did so beautifully. We will ask our friends to put some questions. Some questions have come up in the chat box. Question from Dr. Mukherjee. How do you prevent and manage infections when you're using a venetoclax-based protocol? And what is your personal experience on that?
Yes, so it's a problem when we are using venetoclax and amplified trial. Suppose we are using it along with acalabrutinib. It has to be a graded. First, we need to introduce acalabrutinib, reduce the disease bulk, and then introduce venetoclax. It will help in reducing the incidence of neutropenia and further infections. So this is the primary basic step that we should do, and then prophylaxis should be administered with the antivirals, and PCP prophylaxis should also be initiated when we are using these drugs, as is with the FCR chemotherapy. We have been using that. So and especially we should have a very high level of suspicion if patients develop a fever or they develop any sign of sepsis. Then especially the first month is very important, where we need to have a very close watch on the chance of infection.
Thank you. The other question is there a subset of CLL patients who are potentially curable And can this be predicted?
Yes, so if we are using continuous therapies, the chance of getting MRD negative state is quite less, and patients usually do not achieve that MRD negative state. But patients who are on fixed duration therapy with venetoclax and obinutuzumab or venetoclax acalabrutinib and obinutuzumab, about 30-40% of patients they actually achieve MRD negative state. And we have seen from the chart that 6-7 year PFS rates are quite encouraging. More than 60% of patients they don't tend to they don't have a progression of disease, so attaining a kind of functional cure. So when if we are offering this therapy, CLL therapy, to a young patient, probably we should be doing MRD more frequently, and a functional cure can be achieved in a subset of patients, especially in good risk patients with mutated IGHV status.
You. One more question is related to vaccination in CLL patients. What is the best time?
Best time actually is to start vaccination, give vaccination just before the initiation of treatment. And rituximab is known to interfere, and obinutuzumab is known to interfere with the B cell immunity, and it's better to give before. Vaccinations which we have been commonly using are the influenza, Minfluvac plus Shingrix and the Pneumovac. But even if you are not able to give before, it should be given at any point of time, and especially when disease is under control.
Thank you. Is it possible to diagnose Richter transformation before it becomes symptomatic?
Unfortunately, it's not such an easy diagnosis to make, and it requires very high level of clinical suspicion. Patients they tend to develop fever, and they have B symptoms, weight loss. So a patient who is apparently well, patient of CLL who comes to you with fever, weight loss, large lymph nodes which have suddenly increased in size, then we should do a PET CT scan or CT scan just to see whether there is any progression of lymphadenopathy, and whether there is any sign of disease progression, and it should be biopsied immediately. Then we can probably tackle it in a better way, because Richter's transformation, especially to non-Hodgkin lymphoma, is a difficult situation, and outcomes are not very good in that case, especially.
Thank you. Another one is, present treatment controls the malignant lymphocyte. Are there any treatment to restore the T cell and NK cell function?
The best way is to control the disease itself, and with that, immunity comes back to normal in most of the cases. In bone marrow transplant, depending upon the transplant, it takes about 1 year for immunity to come back. And in the same way, once you control the disease, probably you will get the T cell and NK cell immunity in a better way. But I'm not sure whether there is any study on that. And I'm not aware of any specific information about that.
Dr. Ashok Meshram, your question.
Thank you, Dr. Gaurav, for very informative lecture on fixed duration therapy in CLL. My question is how one should approach sequencing a therapy after relapse following fixed duration therapy, whether we give a doublet, triplet, fixed duration, or continuous therapy.
So that's a very important question, and if you are using first fixed duration therapy upfront, then same therapy can be used down the line, and the chance of having mutations is less when you are using fixed duration therapy. So same therapy can be used again, and again, it is better to use different. It is better to use BTK inhibitor therapy if you are using fixed duration therapy upfront, because again, that has a different mechanism of action, and probably better control would be achieved. But at the other hand, if you are using continuous therapy and patients develop progression on, say, ibrutinib or acalabrutinib, then sometimes it is difficult to use the same therapy again.
Thank you. Thank you.
Dr. Babita, your question. You are muted, Dr. Babita.
Thanks, Dr. Gaurav, for the excellent talk. Sir, you have very well explained from the evolution of the therapies in the CLL from the continuous to the time-limited ones. Sir, my question is that can we see in the near future the monoclonal antibodies, like you have as the first line of treatment, as a standalone treatment? You have, sir, shown in combination the obinutuzumab in combination with the venetoclax and then FCR and the BR. But can we see in the near future the first line therapy standalone, sir?
It may be if we get some new agent or some effective therapies, but as of now, it has to be used in combination along with the BCL2 inhibitor or BTK inhibitor. So previously we used to use it in very unfit patients, but now with advent of such safe therapies and good treatment options, that single agent therapy is usually not used, and in future nobody knows what is going to happen. Dr. Prantar has told about AI, so maybe if we can feed something to AI and we get something, I don't know. But as of now, according to guidelines, it has to be used in some kind of combination.
Sir, my second query is that what is the risk of relapse in the percentage wise, sir, in the time limited therapies vis-a-vis the continuous ones?
Again, it depends upon the disease characteristic, and it is different for patients who have mutated IGHV versus patients who do not have mutated IGHV status. So it's very important to check IGHV status upfront. Many a times we are not doing it, but it helps us in answering exactly the question that you have asked. In patients who have mutated IGHV status, we can safely say that there is more than 80% chance that you are not going to progress in, say, 6 years' time. Whereas in the other group, in patients who have unmutated IGHV, chances are about 60%, is about 20% less. So this is the broad scenario. And in patients who have 17p deletion, it's better to use continuous therapies like ibrutinib and acalabrutinib. And with that, there is more than 75 to 80% chance that patients are not going to progress in, say, 5 to 6 years' time. So it's important to have a proper characterization of CLL upfront, do IGHV mutation status, do 17p status, and then take this to the patient. But what treatment he wants, what is the long-term outcome rates. Yes, thank you.
Thank you, sir.
Thank you. Dr. Amit Khurana.
Yeah, Dr. Gaurav, wonderful talk. I just wanted to know regarding the TP53 mutation status. You said continuous therapy should be the way forward for those patients who are deletion 17p or TP53. Can we go for triplet therapy upfront for this subgroup of patients?
Yes. So amplified trial, there is very good data that we can use triplet therapy upfront, and only when we are, say, confused between, say, continuous therapy versus time limited therapy, then there is slight benefit with the continuous therapy. There is about 10-15% of PFS benefit. But if we are using triplet therapy, it works very well, as amplified trial has shown. There is a good PFS rate in this subgroup of patients.
Thank you. Can we go for, in place, those patients who are unfit for Ven plus Obino? Can we go for Ven plus R as upfront in place of Obino?
Ven plus R has been discussed a few times.
Setting. not in the frontline setting. So can we go for replace Obino with R in the frontline setting?
Yes, so that has been analyzed in various studies, but it has not been found to be beneficial. And the benefit in, I have not discussed this, but in Murano trial and in other trials, when is beneficial with rituximab only in the relapsed setting. In initial like upfront therapy, it has not been found to be useful. The reason why this is so, I don't know. Maybe I don't know what is the reason, but the benefit is seen more in patients who have relapsed, and it's better to use Ven plus R in relapsed case and Ven plus obinutuzumab in patients who are being offered frontline therapy.
Thank you.
There's a distinct advantage of using Obino. It is far, far superior than using rituximab. And when they conducted the trial, they, in the relapse setting, used rituximab, presuming that Obino has been used upfront.
That is a
The mechanism of action of Obino is such that in CLL it is far, far, far superior. So it's not a replacement. We often do it because of the cost factor. Dr. Deep Gala, your question.
Thank you, sir, for this comprehensive overview of CLL frontline management. So, question is regarding MRD in CLL. Do you use in any scenario MRD testing in CLL, especially with fixed drug combinations like Ven-Obin or Ven-Acala?
I'm not using in my clinical practice. I'm not sure whether anybody is using that. It has only been used in clinical trial, and it has been found that if you are using fixed duration therapy, then a chance of attaining MRD negative state is much better. About 40-50% of patients, they have achieved MRD negative bone marrow states. But how to use it and whether we should use it to guide therapy, I think this is immature and probably it won't be a question as of now, at least now. We don't know about the future.
Yes, and any experience with CAR T cell therapy in CLL, sir? Especially Indian CAR will, and do you think that the Indian CAR will work in a relapsed CLL who have failed who have failed BTK inhibitors?
I'm again, I don't know whether Immunoact or Immunil, they have any data about this, how many CLL patients are there. But in patients who have progressive, who have Richter's transformation, they behave like DLBCL, and probably that is one space where we can use CAR T cell therapy. But I'm not sure about data whether CLL patients of CLL has been they are offered with this therapy or not. And in fact, it is not there in guidelines also.
No, they have not included any CLL patients. So just wanted to know,
Okay.
will the CAR T work or it will fail? Because like Axi-cell, they do not work for CLL, only Lysocell works. So will this Indian CAR T, given a scenario, will the Indian CAR T will work or fail? Just wanted to know.
Yeah, with so many CAR Ts now coming up, it may be something which we are going to which we are all going to know in next few years to come.
Thank you, sir.
Deep, there is no Indian CAR T for CLL at all, not even at the research level.
Yeah.
And MRD at the moment gives you the predictor of duration of progression-free survival. So if you have achieved MRD negativity and if you've done the test, it will just tell you that probably the PFS will be longer.
Yes.
But you are not changing the duration of treatment based on MRD.
Yes. So, sir, just to know, like, should we monitor in such scenarios MRD or?
So if you do MRD and if it is negative versus if it is positive, the progression-free survival of a patient who has become MRD negative after, say, 1 year of fixed duration therapy using venetoclax with obinutuzumab or even double oral therapy. MRD negativity gives you an idea about the longer progression-free survival. It does not at the moment allow you to continue the treatment based on MRD, as Gaurav mentioned. That is under study, that continuing the treatment, whether there are any benefits. So fixed duration therapy using when is fixed duration therapy, 1 year, and you stop it there, irrespective of that.
Thank you, sir.
Some more questions have come up. Dr. Manju wants to know, are there clear-cut indications for CAR-T in CLL patients?
I think we have discussed that, and sir, you yourself have answered this question. So Indian CAR-T, there is no such trial which is going on.
Yeah, so Dr. Manju, it is not the frontline therapy. It is after failure of both the drugs that you have. So in the Western world, you also have PERTO, which we do not have. They are also researching on the BTK degraders, which will take time to come in the clinical practice. So BTKI, BCL2I, BTK degraders, PERTO, covalent. If all these are over, then probably CAR-T, because CAR-T in CLL is not that effective as CAR-T in ALL and DLBCL. The next question that has come up is, we continue BTKI when the patient has developed, do we continue BTKI when the patient has developed infection?
So as practice, I don't continue in case patients develop infection, and infection is always the first priority. We treat infections first. We find out the focus of infection. We treat it, and once patients are like they have recovered, only then we think of starting, because CLL is never an emergency, whereas infection is kind of emergency in patients of CLL. So it is something which we consider only after patient recovers.
Absolutely. Infection is the biggest fear where the patient can die. So that takes the priority. There are no more questions in the chat box. Anybody here wants to ask any question to Dr. Gaurav? Okay, so I think we've done with. So Dr. Gaurav, thank you so much. Wonderful
Thank you,
talk,
sir.
great QA session. Enjoyed, learned a lot. And I'm sure everybody benefited. We already have about 20 participants on this side, and over 100 have logged in to listen to you. Thank you.
Thank you so much, sir. Thank you.
Good night. Bye.